tendoachilles tendinosis. What are the symptoms and signs? You all know. Pain in the heel in the morning. Pain in the heel after getting up from sitting. But as the day goes by, the pain reduces. Many a time, not responding to physiotherapy, shortwave diathermy, ultrasonics, ice, lot of things the physiotherapists they give, but may respond, may not respond. Never respond to NSAIDs once again, because as I told you in tennis elbow, there is no inflammation, there is a degeneration. So how NSAIDs are going to work? They are not going to work. Now never respond to that towel gathering, that they say that you put the towel on the floor and start gathering with your toes. That also is not going to work. Nothing is going to work. And the heel is going to pain. Ye dalo, this footwear, that footwear, don't wear heels, don't dance, this, that. These are all hallucinations. Nothing is going to work. It's not scientific. So not responding to change of footwear, nothing is going to happen. Right? So on examination, the foot has a cavus. The corollary is that flat foot never have heel pain. They never ever have calcaneal spur. And that is the crux of the issue. There is a tightness of TA. So whenever there is a TA tendinosis, the patient will get tightness of TA. Limitation of dorsiflexion of the foot. They never get full dorsiflexion of the foot when the patient has got TA tendinosis. But that doesn't mean that he will not have plantar fasciitis. Both are different. Next, pressure on the metatarsal heads. When you press on the metatarsal heads this way, you will find tenderness in the heel at the origin of plantar fascia. So you do this, you will have tenderness over here at the origin of plantar fascia. And sometimes you get tenderness and swelling and bone growth at the tendoachilles insertion. So this is the heel spur. So this is the heel spur, and that is, can you see the pointer there? So this is the heel spur, that is plantar fasciitis, and this is the retrocalcaneus spur. Okay. What is the cause? The heel spur is not the cause of pain. Where is the heel spur? Is the heel spur going down to the floor? No. It is going in the direction of the plantar fascia. Similarly, the calcaneal spur, that also will go in the direction of tendoachilles. That means these are the structures which are tight and they are the causing spurs. So it is like that katipatang. Now when that katipatang is tight, it will get cut. If you give dheel, it will go on, and provided the other guy's manja is stronger, it will cut. Otherwise it is not going to cut. You hold it tight, it will get it cut. So that is the funda of this principle of treatment. And that is next. So what do you do for these patients? You must do a uric acid if you wish. That you can do later if there is no symptom free. But this is what one should do. Now, this is what I do, and that is the leg will be, the knee joint is straight. Okay? The leg should touch the floor. The heel should touch the wall. Okay? And the metatarsal bar. Now what is this metatarsal bar? This is nothing but a wooden plank of plywood. So normally in the plywood shop you get planks which are 3/4 inch. So you can have 3/4 inch, that is comfortable. If patient can tolerate, you can put 1.5 inch, that is 2 plies. So this is available in the plywood shop. You can tell the patient to go to the plywood shop and get that. Earlier I used to use dhoka. The dhoka also used to be 1 inch, but with the use of washing machine, the dhokas have disappeared, so they are not available. So there. Now this is a mistake. This lady, what is she doing? Her knee is straight, but the calf is not touching the floor. Now this wooden plank is actually not necessary for the patient in the house. This is for our clinic. You can't have so many patients' feet touching the wall and getting it dirty. So there it is. And this is also wrong. What is happening over here? The patient's foot is on the heel is on the wall, but it is away from the floor. So this is important. Straight leg, calf touching, this touching, heel touching here, and metatarsal bar. You tell the patient to do this 10 minutes twice a day. In your clinic, if he does it, he comes with heel pain, and you tell the patient to do for 10 minutes. Just as I told you, when you do the TheraBand for tennis elbow, patient will go without pain. Here also, a patient who says pain, pain, now see, is there any pain? He said, no, Hari, my pain is gone. This is the patient who will respond to your treatment. If it is not responding, then you can do uric acid or something. But otherwise, this patient always, I have never, very rarely I have given a injection depomedrol or Premaxor or hydrocortisone acetate. The first thing is injection लेना पड़ेगा. नहीं, injection नहीं, और कुछ तो बताओ, this is a treatment. You give that, mostly 95% of the patient have got KAVAS, they have got a tight plantar fascia, or they have got a tight tendo Achilles, and they respond. The next thing is that you tell the patient, young patient, it should not be old patient, otherwise he may rupture, but a young patient, now this is my clinic stool, but you can tell the patient to stand this way for 3 minutes on the society step, and no oscillation. He should not do this. Just stand for 3 minutes. Just stand for 3 minutes. So what he is doing? He is doing the same thing like metatarsal bar. This same lady, she is also doing the same. Now what are the things? He has to stand on the metatarsal. The heel has to go down. So what is happening? The same thing. The knee is straight. The heel is stretching. The plantar fascia is stretching because the patient is on the metatarsal head. This patient also will have relief of pain. So you do these two things. One is the metatarsal bar, 3/4 inch or 1.5 inch. You will get it in the plywood shop. You tell the patient to get it. You don't keep on supplying metatarsal bar to the patient. Let the patient go and get it. No problem. And they get it. Or standing, and then of course, along with that, standing for 3 minutes on the society step. Last step, not the first, the highest step, they might fall. So the first step of the society, make a note of that also. So what are the outcomes? My outcomes, 95%, I have never, I don't even remember when I have given a hydrocortisone injection in the heel. They just don't come. Achha, abhi acha lagta. The moment he says going out acha lagta means that's it. He's going to respond. Never. You all know, never give a steroid in injection TA. If you give even 1 ml, the tendo Achilles is going to tear. Patient with less. Now sometimes you get patient with less heel pad. Somehow God has not given them the heel pad only. These are the patients who don't respond normally to anything. In those cases, I tell them, you buy footwear with good sponge, and that should be, because their God has not given them sponge. So you give them artificial sponge, so that works. And as I said, I have yet to give steroid. Actually, it is very painful. You give local, then you give that, and then patient shouting and all that. So all that, injection के बिना हो सकता है, कहाँ हो सकता है, ये try करना है क्या? Yeah. They are very happy with that. So do that. Don't give any steroid, and I haven't for many years. This is my treatment for plantar fasciitis and tendo Achilles tendinosis. Okay, thank you.